Everyone. Today we are here again with another step session for the nurses, and the topic of today is renal failure in ICU. We know there is a large burden of patients in the ICU with sepsis, and sepsis associated acute kidney injury is a very common complication with significant acute and long-term complications. The incidence varying to as high as 10 to 50%, and the mortality of AKI in ICU is 50 to 60%. Every one out of your two patients has a very high probability to die. And in spite of the increased recognition of AKI and use of RRT, 20% patients still remain on long-term dialysis. So which affects the increased cost and quality of life of patients. So once we have realized that AKI is such a devastating problem, what can we as healthcare workers or healthcare professionals do or change our management strategies so that we can prevent or at least decrease the rate of occurrence? So there are certain management strategies which can be clubbed together as the VAP bundle, the COTI bundle, they can be an AKI bundle. So for discussion of what is renal failure in the ICU today, we have today with us no better person than Dr. Kanwal Preet Sodhi herself, who is the Director of Critical Care at Deep Hospital, Ludhiana. She has many achievements to her credit, and few of them are that she is the lead author of the guidelines on AKI published in our Journal of Indian Journal of Critical Care Medicine 2022. And she is also the lead, national lead for the RRT workshop at Criticare 2024. So over to you, Dr. Kanwal Preet.
Thank you, Dr. Gunjan. And good afternoon all. Madam has given my introduction. I would like to highlight few things that I want that this session be an interactive one rather than being a one-side, just a lecture type of thing. So I would like to request everybody to please put in your queries, your questions into the chat box such that we have a good discussion at the end of the session. And whatsoever things you have in mind, please do jot down, and we can have a live interaction also at the end of this lecture. So my topic is renal failure in ICU. I would like to say that when we talk about the renal failure, it is actually, the terminology is these days acute kidney injury. So we always talk about acute kidney injury in ICU, and we'll be having two sessions for this specific topic. Since one is about acute kidney injury per se, and the next one will be about the renal replacement therapy, that is the treatment, the definitive treatment, or we can say the supportive treatment for the acute kidney injury. So in the first talk, we'll be talking only about the acute kidney injury. So the objectives of this class will be, we'll be knowing how to define acute kidney injury, how do we label that the patient has acute kidney injury, then how to stage the AKI, and we have to know the etiology of the AKI, what are the factors which lead on to acute kidney injury in ICU patients, how do we diagnose, especially at the bedside, what are the criteria we use to diagnose AKI in our patients, then about the management, which involves primarily, as Dr. Gunjan was saying, the preventive part is more important rather than the treatment. For the treatment, I think the doctors are the one who treat the patients, but prevention is a part of the nursing job, which we'll be talking about in the later half of this talk. So I start with a case. She's a 48-year-old female, known case of diabetes mellitus type 2, hypothyroid, with history of fever for 4 to 5 days, cough associated with sputum off and on. He had 3 to 4 vomiting episodes since morning of admission and decreased urine output since morning. So the question here is like, now what are we dealing with? I think, can we have the chat box on, Deepa?
Yes, ma'am.
Do we have a chat box on?
Yeah.
I would like to.
It's enabled.
Okay. So from the presumptive, this case history, I think we are treating with a lower respiratory tract infection when patient has some component of sepsis and might be patient is having acute kidney injury. This is a gross observation from this case. So when we talk about acute kidney injury, what do we mean by it? That Thereby, we need to define the deterioration of renal function over a period of hours to days, and which actually results in the failure of kidney to excrete nitrogenous waste products and to maintain the fluid and electrolyte hemostasis. Both are disturbed then. So this is the definition of acute kidney injury, grossly. So the two terminologies we routinely use in AKI, one is oliguria and one is anuria. We must always remember how to differentiate oliguria versus anuria. So oliguria is primarily urine output, a defined amount, that is 400 mils of urine output, lesser than that in 24 hours. And anuria, we say when we have less than 100 mils of urine output in the previous day, that is 24 hours, we get a urine output of less than 100 mils. The ICCM has proposed the guidelines on acute kidney injury, which you all can go through. I have been the lead author for these guidelines. They've been published in 2022, and I would suggest that all of you do go back and just have a look. They may look more comprehensive. They may look somewhat exhaustive also, but to have a broader overview, you must go through these guidelines. So whatever we are talking about today is all part of these guidelines only. So ICCM has also defined AKI based upon the KDIGO, which is the global definition being used for acute kidney injury. So how do we say that the patient has acute kidney injury? There are three criteria given. That might be either of these three criteria. One is increase in serum creatinine by more than equal to 0.3 milligram per deciliter within 48 hours. Like supposedly we say we have a patient who had a creatinine of 2, or supposedly we have a creatinine of 1. On admission, patient's creatinine was 1 milligram per deciliter. And on day 3, patient's creatinine has gone to 1.4. So this will fit into the criteria of AKI, since the creatinine has risen by more than equal to 0.3 milligram per deciliter within 48 hours. The other criteria used is increase in serum creatinine by more than 1.5 times the baseline. If we know the baseline, what was the previous creatinine levels in any patient, we have the previous records available, and the creatinine increases to more than 1.5 times the baseline, right? So within prior 7 days, then we say that the patient is having AKI. And the third criteria, which is most commonly used in ICU, and it is easy to define at the earliest, AKI. When we have a urine output of less than 0.5 mils per kg per hour for 6 hours. Over 6 hours, the patient is pouring out urine output of less than 0.5 mils per kg per hour. Supposedly, we have a 60 kg female, like this patient, which case we had gone, she was a 60 kg female. So if the urine output remains less than 30 mils every hour, 30 mils of urine output per hour for over 6 hours. Supposedly in 6 hours, patient is having 150 mils of urine. Then we will say that the patient has gone into AKI. So within 6 hours, we can define that the patient has acute kidney. And all these criteria, these diagnostic criteria should be applied only after volume status has been optimized. That we have optimally resuscitated the patient is now euvolemic, the patient is not dehydrated, and we need to rule out the cause of any obstructive cause of decrease in urine output. Like if the patient is having some kidney stone or subureteric stone, that has to be excluded if we use the urine volume criteria alone as a definition of AKI. So any of these three criteria can be used to define a patient of AKI. Increase in serum creatinine of more than 0.3 milligram per deciliter within 48 hours. Increase in serum creatinine of more than 1.5 times the baseline within prior 7 days, or urine volume of less than 0.5 mils per kg per hour for 6 hours. So now we continue with the case. On admission, the patient is an altered sensorium. She is somewhat confused. Heart rate is 122 per minute. Blood pressure is 90 by 60 millimeters mercury. Respiratory rate of 32 per minute. Saturation on room air was 92%. Patient was resuscitated with 9 normal saline, 2 liters bolus was given, followed by around 80 mL per hour was started. Patient was subsequently catheterized, and urine output over the next 6 hours was only 50 ml. So now what is the diagnosis? So I think as we have talked about that, we have defined, so you all must be able to define that this patient is having acute kidney injury based upon the definition of urine output. Since the output is only 50 mils in last 6 hours. So now we come on to the staging of AKI. Once we have defined that the patient is having acute kidney injury, now we ought to know at what stage of AKI patient is in. Because as we go, the severity of AKI increases, the stage of AKI also increases. So we have defined AKI into 3 stages, stage 1, 2, and 3. And these stages have been based upon the serum creatinine values or urine output values. Either can be used again. You can have only changes in serum creatinine or only changes in urine output. So any of these criteria can be used. Wherein stage 1, that is 1.5 to 1.9 times the baseline of serum creatinine. Since we have said that more than 1.5 times serum creatinine is acute kidney injury. So if patient has 1.5 times to 1.9 times baseline or more than 3 milligram per deciliter increase in serum creatinine, that is stage 1. And similarly, if we are defining by the urine output criteria, less than 0.5 mils per kg per hour for 6 to 12 hours. That is stage 1. Stage 2, serum creatinine is 2 to 2.9 times the baseline. And in stage 3, more than 3 times the baseline serum creatinine, right? So stage 2 is 2 to 2.9 times the baseline of serum creatinine, or urine output has dropped down to 0.5 ml per kg per hour for more than equal to 12 hours. So if this drop in urine output remains for more than 12 hours, then we say the patient is in stage 2 AKI. Stage 3 AKI, more than 3 times the baseline serum creatinine, or increase in serum creatinine as just a single value of 4 milligram per deciliter. If the serum creatinine is 4.8, straight away you go that patient is in stage 3 AKI. Or the third criteria is patient is on renal replacement therapy. We have started the dialysis for the patient, right? Then again, the patient is in stage 3 AKI. Or in patients less than 18 years, which we routinely don't have in our ICUs because we all deal with adult ICU. So if in patients less than 18 years, there's decrease in eGFR to less than 35 mils per minute per 1.73 meters square. So this is the serum creatinine criteria for stage 3. More than 3 times the baseline, increase in value of more than 4, or patient on RRT. And for urine output, there is further drop in urine output. Like now the urine output is less than 0.3 mils per kg per hour for more than 24 hours, or patient is anuric for more than 12 hours. Anuric means less than 100 mils over 24 hours, right? So these are the stages of AKI, which grossly you should know: 1.5 to 1.9 times serum creatinine, stage 1, 2 to 2.9, stage 2, and more than 3 times or absolute value of serum creatinine 4, or patient on RRT, stage 3 AKI, right? And similarly for urine output, 0.5 mils per kg per hour for 6 to 12 hours, 1 for more than 12 hours, stage 2, and less than 0.3 for more than 24 hours, it is stage 3 AKI. This might seem somewhat confusing, but if you go again and reinforce in your minds, then it is easier to remember. Because staging of AKI does matter, because if we diagnose the patient earlier, like in the first 6 to 12 hours, if we are able to diagnose that the urine output has dropped, then it is easier to treat, rather than letting the patient go into stage 3 AKI, that the patient remained anuric, and then we are looking at that, oh, my patient has gone into AKI. So then, because we have to intensify the treatment then. Right. So I have an MCQ for all of you. I would like that please do put your answers into the chat box. So this is AKI is defined as criteria. A is urine output of less than 0.5 mils per kg in last 4 hours. Serum creatinine of more than 1.5 times the baseline creatinine. Doubling of serum creatinine or no urine in 1 hour. Please put down your answers in the chat box. I think all of you are listening to me. Yes, we have one answer. So, B, good. So, yes, the answer is B.
The message is
right?
conveyed. Huh.
Yeah, message is conveyed. So, the prime thing is like, just remember the gross things. We don't want that you become the masters of nephrology. We are not to become the nephrologists. But yes, you are the faces of ICU. So you are the ones who always let us know. I just sit on my chair and then my staff nurse comes to me and tells me, ma'am, her urine output is decreased. It's only 20 mils in last 1 hour. So that is important for me. That is a signal you all can give, right? Okay. So somebody is raising her hand. We'll have a live chat at the end of the session. I request you to please. Okay, thank you. So another MCQ. So anuria, how do we define anuria? Anuria defined as low urine output less than 1 liter per day, urine output less than 400 mils per day, or urine output of less than 100 mils per day. Please put in your chat. Very good. Shivaraj, Sinai, Sijo, Lalita. Okay, good. So we have many answers. Thank you for interacting. So the answer is urine output of less than 100 mils per day. That is anuria. Less than 400 mils per day is oliguria, right? And low urine output does not, mean anything. We have to have objective criteria. Low urine output for somebody might mean 50 ml is less. For if it is a 100 kg person, as per the weight of the patient, it will differ. So we cannot just say low urine output. That is not. And urine output of less than 1 liter per day, again, it is, I think, an okay amount. So oliguria and anuria terms you must know, right? Okay. So let's continue with the case. So we had sent the investigations and grossly we have received the CTC and the RFTs. Hemoglobin is 12.5 grams per deciliter. TLC is 21,000 per millimeter cube. Blood urea is 128 milligram per deciliter. Serum creatinine is 3.8 milligram per deciliter. Sodium is 136. Potassium is 5.4. Chloride is 87. And patient remained anuric for more than 18 months. So now, what is your diagnosis? In which stage of AKI patient is in? Please put down in your chat box. This patient is in which stage of AKI? Anyone?
Yes, we have one answer, C.
See, there is, have we talked about that, what is stage C AKI? I think I have not spoken about. We have talked about only 3 stages of AKI, stage 1, stage 2, stage 3. So now this patient, what are the abnormalities the patient is having? Patient is having a TLC of 21,000, blood urea is 128, serum creatinine of 3.8, right? Electrolytes, grossly potassium is 5.4, and patient has remained anuric for more than 18 months. Mansuria is saying acute kidney failure. Lalita is saying D. What do you, I would like to ask you, please, what do you mean by D? I'm asking about the stage of AKI. What is the stage of AKI?
Answer only in stage 1, 2, or 3.
1, 2, 3. Should I go back to the last slide? Stage 1. Somebody is writing stage 1. How do we say stage 1? See. Now, the patient has a serum creatinine of 3.8. I do not know what is the baseline creatinine, one thing, right? But I'm saying that the patient is anuric for around 18 hours. So anuria for more than equal to 12 hours. That is the urine output criteria for stage 3, right? So our patient is in stage 3 AKI, right? Okay. So now let's talk about some theoretical things which we should know. AKI, as Dr. Gunjan was saying, it does occur in up to 5% of hospitalized patients, but up to 35% to 50% of ICU patients. But in ICU, the mortality is very high, up to 75 to 90% in patients with sepsis-associated AKI, and 35 to 45% in those without sepsis, right? So we are thereby very much concerned that we diagnose AKI early and we start treating it, right? So when we talk about the causes of AKI, we divide into three things. One is pre-renal, then we talk about renal and the post-renal causes. Pre-renal means something which is occurring before the kidneys, right? Something like there is some drop in the blood flow, like there's some problem with the blood flow, the volume is less, right? So sudden drop in blood pressure, like patient is in shock, or interruption of blood flow to the kidneys from severe injury or illness, that will cause a pre-renal AKI. Then comes the renal causes. That is, there is some direct damage to the kidneys, which might be because of infection, because of toxins, because of drugs, or reduced blood supply. So that is leading to renal AKI, right? At post-renal cause. Post-renal AKI occurs when there is sudden obstruction of urine flow due to enlarged prostate, or there is ureteric obstruction due to ureteric stone, there is bladder tumor, injury, anything that leads to decrease in the like outflow obstruction is there. Like kidney has produced adequate amount of urine, but that urine cannot flow out of the body. So that is a post-renal cause of AKI, right? So pre-renal AKI, this is the one modality which we deal maximally in our patients. In ICU patients, we almost always have to look for the pre-renal AKI. And this is one thing which is easily treatable. If we know the cause, we can treat that and prevent the AKI too, right? So volume depletion is one of the most important causes of pre-renal AKI. And volume depletion might occur because of renal losses, wherein we have used the diuretics, excessive use of diuretics, patient is polyuric. There are GI losses, like there's excessive vomiting, diarrhea, or there is hemorrhage occurring. Hemorrhage from any side. It might be GI bleed, it might be surgical site hemorrhage, right? So it might be trauma, anything. Hemorrhage will lead on to volume depletion, and ultimately volume depletion will lead on to acute kidney injury. Then it can be shock because of, again, these losses, GI losses, hypovolemic shock, which we talk about, right? So all this volume depletion will lead into hypovolemic shock. Similar is with cutaneous losses like burns, Stevens-Johnson syndrome. In pancreatitis, again, there is massive volume depletion. So all these will lead on to shock, that is mostly hypovolemic shock, and pre-renal AKI can occur. And if we can have a look at these causes, we know that something is occurring. There's excessive vomiting, diarrhea, patient has passed around 10 to 12 stools. So we ought to take care of and replace the fluids adequately. The other cause of pre-renal AKI is decreased cardiac output. Like the volume is okay, but cardiac output itself is decreased. This again will lead on to pre-renal AKI. This might be because of heart failure, pulmonary embolism, acute myocardial infarctions, valvular heart disease, or even the abdominal compartment syndrome. You all must have just listened somewhere in your ICUs that patient is into ACS, or intra-abdominal hypertension has occurred. This again decreases the blood flow to the kidneys, right? Because of tense ascites, there is abdominal issues are there, patient's abdomen is tense, and this will lead on to decrease in the kidney blood flow. Again, we have to treat this abdominal compartment syndrome and prevent the AKI to occur. Then there are the intrinsic renal causes because of the renal injury, which might be because of the glomerular disease, which might be tubular injury, interstitial nephritis, or the vascular disease. These diseases actually, not much can be done about the renal causes except for the tubular injury. Ischemia and toxins, they can be avoided. Like ATM, this acute tubular injury, acute tubular This is one of the things which we can prevent. Again, ischemia we can prevent. It can be because of toxins like pigments, like rhabdomyolysis after trauma, intravascular hemolysis. Crystals can deposit in the tubules. There can be tumor lysis syndrome. Seizures can potentiate ATM, ethylene glycol poisoning, vitamin C excessive doses that has shown to cause ATM, acyclovir, indinavir, methotrexate, and drugs like aminoglycosides. This is one of the most common causes of kidney injury, AKI in the ICUs. So we ought to know all these drugs, the aminoglycosides, lithium, amphotericin B, pentamidine, cisplatin, radiocontrast agents. Again, all these agents, they cause tubular injury. And if any of these drugs is being used in the ICU patient, so we should be very attentive. We should rather be alert that yes, we are using some nephrotoxic drugs and which might need to be stopped at the earliest if there are any signs of AKI. Then there can be glomerular disease or interstitial nephritis. They are actually not very much preventable because they are more part of the causes of the chronic renal injury, chronic kidney injury. Then we have the post-renal AKI because of the ureteric obstruction, which might be because of stone, tumor, fibrosis, or there is ligation occurring during the pelvic surgeries. Then there can be bladder neck obstruction, mainly due to prostatic hypertrophy, cancer of prostate, neurogenic bladder, and even the drugs like tricyclic antidepressants, ganglion blockers, they can all lead to bladder neck obstruction, bladder tumors, or stones in the bladder, or hemorrhage or clot. Or there can be urethral obstruction, which can be in the form of strictures or tumors. So all these can cause post-renal AKI, thereby meaning that the urine production is okay, but there is decrease in the urine outflow. Okay, so I have another question for all of you. Which of the following is not a cause of pre-renal AKI? Shock, diarrhea, ureteric stone, vomitings. Please be fast and put your answers into the chat box. Not a cause of pre-renal AKI.
A.
A.
Somebody's answered A. B.
B. Not a cause.
B.
C. A, B, C.
We have one C.
C. Anybody else?
C.
So there's lots of controversy. When we
Another
talk
C.
about pre-renal AKI, we say that the volume loss, right, or some type of shock has prevented, like that has decreased the renal blood flows. That is a cause of pre-renal AKI. Like before the kidneys, right? So shock can lead to pre-renal AKI, diarrhea, excessive loss, right? GI loss, vomitings, they all can lead to renal AKI. Ureteric stone, C, answer C, is a post-renal cause of AKI. We have just discussed, right? Post-renal means after the kidneys. Okay. So now, what is important from the clinical point of view? We must know the risk factors for AKI when we are in the ICUs, especially. But there are certain patient risk factors, like wherein those are not usually modifiable, but these are the patients who are especially susceptible for kidney injury. So they can be the elderly population, especially those over 75 years, they're very prone to kidney injury occurring in the ICUs. Then coexisting comorbidities, diabetes, especially like in our patient, again, we have, she's a known patient, known case of diabetes mellitus, heart failure, liver disease, peripheral vascular disease, patients who are chronic kidney disease patients, CKD patients, right? So acute on chronic is a common occurrence, acute on chronic kidney. Then patients who have cognitive impairment, they are all patients risk factors, which means that these are the patients who are potentially at risk for developing AKI in the ICUs, right? And most important is to look for these factors because these are the risk factors of AKI ICU patients. Most common, At the beginning of this session, Dr. Gunjan very rightly said that sepsis is the most common cause of AKI in our patients. And you must have seen more than 50% of our patients are sepsis patients, right? So any patient with sepsis, he or she is potentially at risk of AKI. Hypotension. Any fall in blood pressure can lead on to AKI. Hypovolemia. Volume. Patient is hypovolemic because of any cause. So hypotension, hypovolemia, all these can cause pre-renal AKI. Major surgery, again, because of mostly hypovolemia, right? Major surgery patients are again at very high risk of AKI. And there are certain high-risk medications we have already talked about, and we'll be again later on in the subsequent slides, we'll be talking about what are the high-risk medications. Wherein we know these are the drugs which are ongoing and patient can have acute kidney injury. And so we should always have a high alert, like we should always look for the urine output, which we routinely also do. But if we know these are the drugs being, patient is on, patient is on aminoglycosides, patient is on vancomycin, patient is on amphotericin B, patient is on diuretics, we must be very vigilant about the urine output. We must get the daily creatinine levels done such that we diagnose the acute kidney injury if at all it occurs at an early stage. Then the contrast scans. If the patient has to undergo contrast scan, patient has to go a contrast CT scan, patient has to go for angiography, we are giving radio contrast, which are again nephrotoxic, right? So these are all the risk factors of AKI in ICU patients, and we should be very vigilant about looking at these factors. And when we know these factors, we have to treat the underlying cause. Like if the patient is hypovolemic, we have to give fluids. If the patient is in hypertension, along with fluids, we have to start with vasopressors or the inotrops, right? So now, what are the signs and symptoms of AKI? Usually our patients, most of the times, they don't have any symptoms because the routine symptoms might be increased thirst. Some patients might complain because they are getting hypovolemic. There can be evidence of dehydration. There can be loss of turgor. Patients will appear dry, dehydrated, right? Patient can have urine decrease in urine output, although not that early. But as soon as you recognize the patient is having decrease in urine output, please, you have to knock the doors of the doctor, right? And it changes in urine color, especially if the patient is dehydrated, you will start having dark colored urine, right? That also is a sign that patient is dehydrated and or patient might be going into ATM, right? Shortness of breath. This mostly occurs when the patient, because of persistent decrease in urine output, patient goes into fluid overload. Then patient will start having difficulty in breathing. Patient will have fall in saturation, right? SpO2 on room air, initially it was 98, 97%. But over 6-7 hours, patient's SpO2 has dropped down to 88. So you have to be vigilant. Patient is not passing urine. Patient has a drop in saturation. So that can just pinpoint to that patient is getting fluid overload. Then patient will complain of nausea, vomiting because of uremia. Patient can have confusion, drowsiness, again, uremic encephalopathy. Right? So if we do the physical examination, again, volume status, we have talked about that we have to look for any signs of dehydration, blood pressure, pulse, SpO2. We just discussed that SpO2 can be a drop in saturation, can be a pointer that yes, patient is getting fluid overload. Then we can look at the GVT, urine output, urine color, and the sensorium. They all can tell you that patient might be going into acute kidney injury. So now we want to diagnose, right? Bedside parameter is urine output. That is the best parameter. Urine output, early urine charting we do in all ICUs in all patients, right? So if at all patient is having drop in urine output, we say 6 hours, and you get to it, yes, that patient is having acute kidney injury. But then how we make a diagnosis? Again, there are certain lab parameters, the renal function test being the primemost, blood urea nitrogen, serum creatinine, and electrolytes. We have to do a CBC, a peripheral smear. We have to do our urine analysis. Urine routine examination is of prime importance. Then we do a arterial blood gas. Then to rule out the obstructive causes or the post-renal causes, ultrasound, AUB is mandatory, right? Then we can do ECG or chest X-ray. Chest X-ray can be supportive. And for the renal causes, usually we have to go in for serology, which we will not enumerate here. So what are the expected abnormalities in any patient who's in AKI? What lab abnormalities we'll see routinely, usually? We can have a low hemoglobin. We know that erythropoietin is low in renal failure, so patient can have drop in hemoglobin, low hemoglobin. Because of sepsis, patient can be having high TLC counts. In RFTs, we'll see an increase in the blood urea nitrogen levels, increase in serum creatinine. Electrolyte abnormalities usually seen most common is the hyperkalemia. Increase in the potassium is the most common associated abnormality, dyselectrolytemia in AKI patients. Then there can be increased phosphorus, and usually AKI patients have low calcium levels. What we routinely see in the arterial blood gas, that is the most common and most usual abnormality in the blood gas, is metabolic acidosis. Metabolic acidosis is the most common arterial blood gas abnormality in AKI, and usually it is a high anion gap metabolic acidosis, wherein we will have pH will be less than 7.4, bicarbonates will be decreased. Patient will have, because of the low bicarbs, patient will try to wash out the CO2, thereby low CO2 levels and increase in the potassium levels. Uric acid is usually high in AKI, and the ultrasonography can show renal stones, obstruction, hydronephrosis, or the small shrunken kidneys, except for diabetic patients. Usually, if we get an X-ray patient who is on fluid overload, we can have this type of picture, which can show the signs of fluid overload can be there. Urine analysis. Urine routine is a simple, non-invasive, easy to perform test early signs of kidney damage. Because whenever kidney damage occurs, there will be loss of proteins and the blood leak into the urine. So we will have proteinuria, we will have blood in the urine, but usually it is unremarkable in pre and post-renal causes, because pre-renal causes are occurring because of fall in blood flow to the kidneys, and post-renal we have obstruction to the urine flow. But mostly urine analysis is most useful if there are renal causes of AKI. Like this is to differentiate. I don't like tell you that to remember these, but just for your information, there are usually muddy brown casts in ATN, WBC casts in acute ischemic necrosis, and RBC casts in glomerulonephritis, right? So these are usually, again, we can get the urinary indices, fractional extraction of sodium, urine electrolytes. I don't ask you to remember all these. Just for your information, if we have to differentiate the pre-renal versus renal, we can look at the blood urea nitrogen to creatinine ratio, which is very high in pre-renal disease as compared to the renal AKI. Again, urine analysis may be normal or near normal in pre-renal disease. I have already told you, but they can be granular casts, tubular epithelial cells in renal disease. Urine osmolality, again, it is very high in pre-renal, more than 500 milliosmoles per kg. But urine osmolality is low in renal failure. Urine osmolality, high osmolality means that fluid is less, but there are more solute volume. So solute load is very high, right? Again, we have the urinary sodium and the fractional extraction of sodium. Please do not remember, but just remember that usually urine osmolality is very high in pre-renal disease, and blood urea nitrogen to creatinine ratio is also higher in pre-renal disease. Okay. MCQ 4. Which of the following lab abnormality is not usually seen in AKI? Low potassium, high blood urea, low pH, low HP. Which of the following? Please drop down your answers in the chat box.
We have one answer A.
A. Anybody else? Pile nothing. So yes, please put down your answers. So answer is
A
A.
and
Right? So low potassium. Usually we see most common lab abnormality seen in AKI is high potassium levels. Hyperkalemia is the most common electrical disturbance, right? Okay. Another question. AKI is associated most commonly with what is the blood gas abnormality? Most common blood gas abnormality. Please put your answers in the chat box. C. Anybody else? C. I think what?
yes,
Some message they
Yes.
could get. Yes.
many C's.
Metabolic acidosis, high anion gap metabolic acidosis is the most common blood gas abnormality seen in AKI. Right? Okay. So now we have sort of diagnosed what we can do. I told you in the beginning that prevention is what we want to do, right? So to prevent, we have to identify the high-risk population, right? We have talked about the elderly population, diabetics, heart failure patients, right? They all are high-risk populations. We have to identify the contributing risk factors, which we have already talked about, hypovolemia, shock, right? They all are the contributing risk factors, the toxins, the drugs which the patient is on. So we have to reduce the risk from these medications and improve management of fluid prescription and fluid balance. So this is what we bundled it as AKI care bundle. As Dr. Gunjan was saying, when we talk about the VAP bundle, the CLAPSI bundle, we all know about it. But we must know about the AKI care bundle. That means that whenever there are potential risk factors in the patients, in the ICU patients, we must follow this AKI care bundle, which we have recommended in our ICU ICCM guidelines also, that we must follow for all our ICU patients. As a grade 1 recommendation, we have recommended it that we must do the hemodynamic optimization of all patients to set blood pressure targets. We should not allow the patient to be in hypotension for a long time. We must optimize the fluid balance because not only hypovolemia, hypervolemia, when the patient is in fluid overload, that can also compromise the kidneys. So we have to optimize the fluid balance. We have to monitor the kidney function. As I told you in the beginning, that monitoring kidney function at the bedside by using urine output criteria and using the renal, getting the blood labs done along with use of biomarkers for prediction of imminent AKI. Imminent means there is potential AKI that can occur. So they are recommended. We have to go in for nephrotoxin stewardship. That again means that the medications which are potentially nephrotoxic, which are harmful for the kidneys, we ought to stop them or minimize their use. And avoiding hyperglycemia. We must avoid high blood sugar levels. The blood sugar targets in our patients must be between 150 to 180 milligram per deciliter. So they all are the components of AKI care bundle, whereby we mean that all these 5 things must be followed at all times in all patients, right? All these 5: hemodynamic optimization, fluid optimization, monitoring the kidney function, nephrotoxin stewardship, and avoiding the hyperglycemia. So what we can do, we can recognize earlier by bedside monitoring. There are algorithms or e-alerts being used across Western world, whereby they tick mark that this urine output has dropped, the creatinine, yesterday it was 1, now it is 1.3, that means patient has gone into AKI, and those e-alerts directly go to the consultant that your patient is going into acute kidney injury. Then early recognition of deteriorating patients, looking at symptoms, which at the bedside, you are the first ones who look at the symptoms, and you have to alert your doctors. Withholding nephrotoxic medications and avoiding nephrotoxic drug combinations. If the patient is, there's a mandate. As per the culture sensitivity, we have started the patient on vancomycin. We ought to look at other drugs which can be nephrotoxic. Is the patient on mannitol? Is the patient is on diuretic? Then we must avoid all those nephrotoxic drugs. Or if there's a patient who is a neuro patient on traumatic brain injury, we ought to give him mannitol. Then we should avoid some nephrotoxic antibiotic. We should avoid using amikacin in such patients. We should. So if the patient is on 2 or 3 nephrotoxic drugs, you must alert your physician or the consultant, ICU consultant, that, sir, these are the drugs which are ongoing. So can we stop either of them, right? So I know that is not in the purview of the nursing staff to stop the drugs, but you can at least alert, right? So again, respond in the form of that you have to look for screen for sepsis. We have to address the hypovolemia, hydration status should be optimized. We have to look for obstruction by the scans or the ultrasounds done. We have to get a urine analysis and toxins. We have to stop the drugs. So this has been given a mnemonic shout: sepsis, hypovolemia, obstruction, urine analysis, and toxin. So start shouting for prevention of AKI. This is a request for everybody. This has been put in by the Scottish Patient Safety Program that we have to shout to prevent AKI. So the medications we have already discussed. Antibiotics, we know amikacin, vancomycin, colistin, then antifungal like amphotericin. Beyond that, ACE inhibitors. Hypertensive patients can be, cardiac patients can be on ACE inhibitors, or the ARBs like ramipril, lisinopril, losartan, olmesartan, valsartan. Patients we have to avoid NSAIDs, right? Diuretics, furosemide, spironolactone, metformin in another drug which is commonly these are the chronic medications patient is on. So when we follow the medication chart, we must look at all these drugs. Beyond these, the mannitol is another important drug which is used in ICU patients. So all these are potentially nephrotoxic, and we should avoid their use as far as possible. So we have to optimize the hemodynamics by maintaining adequate fluid balance, accurately record the urine output and the intake on a daily basis, and cumulative fluid balance. That is very important, because cumulative fluid balance, that over one day or subsequent 2-3 days, what is the cumulative fluid balance? Is the patient is in positive balance or the negative balance? Then the hourly urine output. Again, we know that is the good clinical indicator of kidney function. In some ICUs, daily weights are also used as good indicator of acute fluid loss or gain. And early institution of vasopressors or inotropes to maintain the blood pressure. So another question for you: which of the following drugs can cause kidney injury? Anybody? Amikacin, meropenem, paracetamol, midazolam. Quick, this is an easy one.
Yes, we have
yes, one. So amikacin is a very common nephrotoxic drug being used. Okay. So coming on to the treatment of AKI. Treatment, this is part of more of the physician's role. We have to optimize the hemodynamic and volume status, avoidance of further renal insults, optimization of nutrition, treatment of cause. That is a mandate. We must treat the cause which is leading on to acute kidney injury, because AKI is not a diagnosis of ICU patients. It occurs concurrently with other problems, right? So when we treat AKI, what we ought to do, we have to correct the fluid overload. We might have to use diuretics, or even we have to do a ultrafiltrate with on renal replacement therapy, right? We can give NIV support. We have to correct the dyselectrolytemia, especially the potassium. We have to correct the metabolic acidosis by the use of soda bicarb if at all needed. Antibiotics if infection is suspected. We have to build up hemoglobin and might have to use blood transfusions if necessary. The patient is bleeding, actively bleeding. So these are all as per the physician orders. And if necessary, institution of renal replacement therapy. One thing I wanted all of you to know is the treatment of hyperkalemia, because all nurses, I think, should be empowered to treat hyperkalemia, because hyperkalemia per se can be fatal. So there are few drugs which you all must be knowing. We use at the outset, we use calcium gluconate because this is a membrane stabilizer and directly antagonize potassium. And we can give 10 ml of 10% solution. And calcium gluconate can be used. Even calcium chloride is used for severe hyperkalemia. And then we use the insulin glucose, dextrose insulin infusions. Then we use the beta agonists like albuterol. We can excrete out the potassium by using the diuretics, furosemide, sodium bicarbonate. Again, you can even shift and excrete also, and the sodium polystyrene sulfonate resins. These have to be used along with lactulose or sucrose, such that we are able.
On your part, it is very important to early recognize AKI. And that can be done when you are monitoring the urine output regularly. That is the best and the earliest method to diagnose before. And you must alert your doctor or the physician that the urine output is dropping, and whatever it is in our hands to prevent the AKI is the most common causes, pre-renal causes. So assessing the volume status, if the patient is losing volume, he's having diarrhea, he's having vomitings, there is hemorrhage, there is upper GI bleed. So replacement of that volume is very important. And patients, you must be on the guard, high alert for patients who are in the ICU and are on the high risk, patients of sepsis, patient of hypertension. Prolonged hypertension, it means patient is having the kidney is not being perfused. So the chances of going into AKI are very high. And once there is AKI, regular monitoring of the blood gases, because the patient can go into acidosis. It is a further vicious cycle. Acidosis leading to acidotic breathing. Patient's bicarb will be low. So in order to maintain, he will hyperventilate and wash out the carbon dioxide. He can get exhausted. The sensorium can be altered. So that can further lead to other complications. And acidosis will lead to hyperkalemia as well, which can lead to arrhythmias. So management of hyperkalemia, you get an ABG done. And if you see there is low glucose or high potassium, that are urgent and that have to be managed while you are informing the physician, while you are waiting for the order from the physician, you must start. If there is hypoglycemia or there is hyperkalemia, there are urgent problems which need to be addressed immediately. Deepa, have you been able to contact?
Yes, I contact her. She said I joined, but she is not joined because maybe network issue है कुछ इसके लिए join नहीं कर पाई.
एक मिनट.
Okay. So anyone wants to ask any questions? You can raise your hands. We'll be able to answer them.
Is Dr. Kanwal Preet Sodhi है?
Dr. Kamal, you're muted.
Sorry, there were some connection issues. Okay, so basically, we'll be talking about the indications and the modalities of renal replacement therapy in a separate session, right? Subsequently, next month, we'll be having another session. So we'll be talking about that. But just to conclude, that AKI is a common issue in all ICU patients. So be alert to diagnose AKI early, right? Look at the symptoms, especially the urine output, the fluid balance, the blood pressures, ongoing medications, and any changes in urine output. You must alert the doctors at the earliest sign of any urine output drops or changes in the renal parameter. And the symptomatic treatment should be instituted immediately. To be continued as a renal replacement therapy, the next session. Thank you, and I would like to have the question. Sorry for the some. Okay.
So there's
So-
one question in the chat box. How by Shakir? How do you assess fluid status in AKI?
Fluid status in AKI, again, see, fluid status assessment is entirely a vast topic, how we assess the fluid status in the ICU patients. But I'll just stop sharing this. Okay. So, fluid status at the bedside, looking at the signs of dehydration, the turgor of the patient, you can look at the, the eyes itself, you can see at the tongue, then you assess the pulse volume, because I'm talking only about the bedside parameters. I'm not talking, because as a bedside nurse, what you have to look for, right? So they all can tell you that the patient is hypovolemic. The pulse volume is a very good parameter, and the patient is having low blood pressures. That can again tell you that the patient is hypovolemic. But if the patient is having, cracks in the chest, you can feel that you can sometimes listen also to the chest that there are gurgling sounds in the chest. Patient is having drop in saturations. The respiratory rate is fast. Patient is becoming tachypneic. They can all point out that the patient might be getting fluid overload. Similarly, the JVP. JVP is a very good parameter wherein you can look at and check the fluid status. Then certainly, as I talked about, not only the urine volume, the urine color, that also can tell you that the patient is, especially if you have a darker urine, that can tell you that yes, patient is hypovolemic. And beyond that, the doctors have many parameters. We have the bedside focus available. We have the ultrasounds available, wherein we have a number of parameters which we should not, we have to talk that as bedside nurses, what all you can look at.
Another question, which is the fluid choice in AKI? Which fluid can be used?
Fluid, the best fluid is the balanced crystalloid. In the balanced crystalloid, the plasmalites and they come, but normal saline can be used, except for if you are not giving unstoppable boluses of normal saline. After 2 liters of bolus normal saline does not cause AKI, as is the the hype that normal saline can cause acute kidney injury, but rarely. We all have used normal saline over years, so normal saline is a good choice. But if there are excessive GI losses, then even finger lactate is a good choice for AKI. Even for AKI, it does not cause, if we have a normal liver function, it does not cause as such lactic acidosis, right? So the fluids which you are using, yes, but no colloids. The starches should not be used because they have potential to cause nephrotoxicity.
Yes, crystalloids are the best choice. Somebody has raised their hand.
Dr. Gunjan, you want to
Somebody else, somebody raised,
Okay.
He's just looking for it.
Yeah, 2 participants raised hands.
Somebody is.
Lanka
Type a question in the chat box if you have.
Yes.
Yes.
You can talk.
Dr. Lanka Bhai, if you can
Unmute yourself.
Unmute yourself.
Ms. Lanka Bhai, please unmute yourself and talk. Or you can drop your question in the chat box. Anyone else who wants to, ask any question? Well, then see, my primary objective of this session will be that you have to be alert that AKI can occur in all ICU patients, right? And you ought to keep in mind what are the potential risk factors of AKI in ICU. Like patient is hypovolemic, hypertension, patient is in shock, patient is on nephrotoxic drugs. So you are the ones who, are the earliest to look at those things. So please alert your physicians that these are the potential harmful nephrotoxic things ongoing. So if we can stop, and obviously you all do the intake output chartings, and once ever we have the drop in urine output, please alert your physicians, right? So that is the prime motive, which is expected of you as bedside nurses. I think we have another question. Okay. What is the diet plan for AKI? But okay. So diet plan, basically the patients, as was previously thought, the patient ought to have low protein diet. That is not currently the norm. The norm is we have to give adequate calories, 25 to 30 kilocalories per kg per day, as there is the patient is already routine ICU patients also have to get the same calories. And AKI patients, they ought to have around 1.2 to 1.5 grams per kg body weight of protein, right? And if the patient is on renal replacement therapy, that is the time when they might need even higher amounts of proteins, up to 2 grams per kg body weight of protein, because there are losses through the RRT also. So diet plans again have to be decided by the consultant, but they have to be, there is no norm now that not to give, low protein diet. There is nothing of that sort. So it has to be a normal energy and normal proteins.
Yes. And I just want to add that it should be potassium-free diet, and especially, and if the patient is anguric, so you can give calorie dense, less of fluids, especially if the patient is not on any renal replacement and there's low urine output, the fluids have to be balanced. You can give calorie dense diets. And I think
calorie dense diets, and also, yes, if the patient is on nasogastric feeds, and obviously no juices, no coconut water.
Potassium free.
Yeah.
So I think no more
Anything
questions. Thank you, Dr. Kanwal. It was a difficult topic, but you've made the things very simplified, and the message has gone through. Thank you.
I hope so. Okay. Thank you so much. Thank you, friends. Thank you.